Okay, let's see whether we can record this. So many emissions. Yeah, you're right. Awesome. I have to keep admitting everyone. Okay. All right. Shall we start?
Yes. Yes, doctor.
Okay. If any point the internet connection is not good, my slide didn't go, or it stopped, or lag, let me know. Because I don't know. If you didn't talk, I don't know. I don't know what happened. I assume everything is okay. So today is cleft lip and palate. Again, this one is considered advanced orthodontic. So this, to be honest, shouldn't be the undergrad topic. But since you already put in, I just try my best to explain everything to you. Hopefully not too heavy. So cleft lip and palate, this one consider multidisciplinary approach. It means that you need a team to do the treatment for these patients. So it involves so many disciplines, not only dental, sometimes medical also. So today's lecture, oops, sorry, someone coming in again. Okay, so we're going to talk about the most common, so we're going to talk about cleft lip palate. Okay, so cleft lip palate is the most common cranial features abnormality and congenitally abnormal space or gap in the upper lips, then alveolar, or the alveolus, or the palate. So they affect the anatomy and function of the lips and the nose, and then the alveolar process, the teeth, the soft tissue and the hard palate, and the ear also. So they also affect the skeletal and soft tissue development. Okay, so there's a typical photograph for the cleft and palate. So it can be so many structures involved. Right? It can be the lips, the nose, the palate, hard palate, soft palate. It can be everything all mashed together. So the incident unilateral cleft lip is the most common. It's about 40%. Then cleft palates about 30%. Bilaterals a bit unusual, the 10%. Then cat lip only about 10%. Others submucosal cleft about 10%. But remember, 75% of the cleft are unilateral. Is it on the left side or the right side? We can talk about that. Then they are more common on the left side. So left to right, the ratio is about 2 to 1. No one know why. Just like some people are left-handed, right-handed. So no one know why. But according to research, the incidence is more to the left to the right compared to the right. Caucasian is 1 to 700. The birth, the ratio. Japanese a bit more usual. Malaysian is 1 to 600. And if you're talking about the numbers or incidents, Malay is more than the Chinese, then the Indian the last. This might be due to the populations. The more is Malay, then followed by Chinese and Indian. And the second sometimes can be inter or the close family marriage, then can contribute to this incident also. Then the gender distributions, unilateral cleft lip and palate, the male is more than the female. Only the cleft palate, the male is less than the female. Then cleft lip also, the female is less than the male. So overall, we can say the cleft lip is more common in male than the female. So what's the etiology of this cleft lip and palate? Multifactorial. So many factors, so many factors involved during this growth of the lip and the palate. The family history can play an important role. It can be genetic. Sometimes the parents are cleft lip palate patients. Then the kid might have a high incidence to happen. Then terogenics, like you drink a lot of alcohol consumptions during the pregnancy. Then nicotine, smoke too much. Then radiations, exposed to X-ray. Then the drug also. Drug is not very common in Malaysia, but in the UK it's very common. So mild drugs, they are allowed, or even they are not allowed. It's very commonly available. They can get it very easily, like the weed and the marijuana. So this one, if you're during a pregnancy, we try not to take the X-ray. That's one of the reasons it might cause the mutation of the gene, then it might cause the cleft lip and palate. Environmental factor, hypoxia can be due to not enough oxygen, hypothermia, then too much of heat, then illness can be other infection during the pregnancy, can cause the disturbance to the growth or the development of the lips and the palate. So this may interfere with the embryonic development. So whatever disturb the growth of the lips and the palate, then that will cause the cleft. So genetic risk. So like I said before, if one of the children have it, then maybe there's a risk for the next children have it also. If the parents are cleft, then maybe high chance the children might have cleft also. So if the one of the children affected, the next children is 1 to 4%. Then if the one of the affected parents, either moms or father is a cleft patient, then the risk of the next patient might be 50%. The next child, the first child birth might be 50%. Half chance then the kid might have cleft. Then if both parents are affected, then it raises up to 60%. The child is going to have a cleft. So I remember my first, my specialist, the ped specialist, I think he told me the first thing he checked when his child's born is whether they have cleft or not. That's the reason why he's so worried. I will tell you why later. Because when they have cleft patients, then basically their child is all messed up. They will go in the hospital multiple times, go for surgery multiple times. Basically, the whole childhood is ruined. Then they're going to in the hospital, out hospital, almost half of the time of their life. So they are quite traumatic for the kids. So what happened is during this growth or the embryology of the cleft palate, this time we talk about the growth. So the frontal nasal process will come down, then it join with the nasal and lateral nasal prominent, then the maxilla and mandible also will join the middle. So everything joined together, then no problem. What happens is if these processes, they fail to join to each other, then they create the cleft. So we have the frontal nasal, then we have the medial and lateral nasal, then we have maxillary, then we have mandible. So you look at this picture. So this picture is just illustrate everything we said just now. So frontal nasal is from the top. Then we have a nasal process. We have the medial and lateral, both. Then we have the top. We have the maxilla coming from the left and right. Then we have the mandible at the bottom. So if all these processes fail to join, then we create the cleft. So occur during the 5th to 6th week of the gestations, then fusion between the frontal nasal and the maxillary processes. So you see this frontal nasal will join to the maxillary prominent. So this one will come down and join the maxillary prominent. If this fail, then create cleft. Fusion defect can occur anyway between these prominences. So any part is not joining, then it creates a cleft. So if everything is not joining, then you see the cleft lip palate everywhere. But if you join, then certain part is not joined, then you see the cleft is not that severe. So it depends. It depends how many part is failed to join, then it determines the severity of the cleft. So the defect between the frontal nasal and the maxillary process prominence will cause the cleft lip. So the primary palate area of the hard palate anterior to the incisor foramen. So the incisor foramen will determine the primary palate and the secondary palate. So they originate from the premaxilla. In front of the foramen, consider premaxilla. Posterior to the foramen, we consider the hard palate. So it develop between the 4 and the 8 weeks of the gestations. Frontal nasal prominent. So the secondary palate, the area posterior to incisive foramen. So made of the hard and soft palate that come from the palatal shelf of the maxillary prominence. So develop between the 8 and 12 weeks. So this one is about 2nd month. So this one about the 3rd month. So primary 3rd month, primary 2nd month, then hard palate 3rd month. So you can see these pictures. So the yellow color is a primary palate. Then the secondary palate is a red colors. So whatever fail to fuse, then it cause a cleft. So this is a maxillary process from the left and right. So everything will join the middle, join the front, then okay. If this fail to join, then create the cleft. So same, huh? Look at the left pictures. I think we talked about this before. So you have the nasal septum on top, then we have the palatal shelf, the blue colors, and have the tongue in the middle. So during the development, the tongue will depress or they'll come down, then the palatal shelf will elevate, then they come to the middle. Then if they join together, then everything's okay. Then divide the nasal cavity to the oral cavity. But if these processes or prominence they fail to join, then create a cleft. So we can see from the palate, same thing, primary, secondary. So if the primary and secondary palate they fail to join together, then they create a cleft. Of course, the incisive foramens will divide the primary and secondary palate. So the reason for cleft, so basically like I say just now, that everything joined together, no problem, but the failure of fusion between these processes or the shell then cause the cleft. So can be fail to join at the superficial level, which is the epithelium, sorry. Or it can be rupture of the fusions. They join, but they rupture again. It means the joint is not strong enough, then they break again. So again, defective mergings of the mesenchyme. Okay, we're going to talk about it one by one. So if you're talking about classification of the cleft, there's so many systems, but many type of classification are descriptive. It means they describe how what they see. So there's so many. This one Kenihan, then about why, then Miller modified it, then finally we come to this Russia. Okay, so this is simple. We look at this shape, it's like Y. So you just divided the cleft to different area. So right side, left side, then you start from the lips, areoles, then hard palate, soft palate. Yeah, that's how they divide it. Descriptive. It can be right side, the lips only, right side, the lip plus the areoles, or the right side, the lip, then plus the areoles, then all the way to the soft palate. That's how to describe it. Then after that, Millet modified this Y, descriptive Y. Then it involved the nose also. They add in the nose, the nasal flow. Then we call it modified Y, modified Kenihan. Then finally we have this Russia. Russia is very simple, same, similar to just now the Y, but it just draw a V, from here is the lips, areola, hard palate, and then finally have soft palate. So you just link this together. The middle is a soft palate, then the left we have a lips, areola, hard palate. On the right side same, lips, areola, hard palate, then middle we have soft palate. That's how they describe it. So many systems, you can describe it according to your preference. So there are other type. So this one, like I say, if a superficial epithelium didn't join, then we can create this microform cleft, only a small dent on the lips, but they don't have a complete cleft because it just failed to join on the superficial level. The deep down, the muscle is all joined. Just the superficial level is not joined. Then we have a submucosa cleft palate and midline deficiency often with the cleft on the uvula. So only the soft palate is have this cleft. It then extend to the hard palate. Okay, so now I think I myself or some of the specialists they prefer to use this picture to describe the cleft. Can be a cleft, lip, hard palate, soft palate, uvula. Unilateral, bilateral. For example, this one is only unilateral cleft lip, then this one bilateral cleft lip, then this one is a cleft palate, unilateral, bilateral cleft palate. Then unilateral can extend to the lips and the full palate. That's how we describe it. Or this one is bilateral cleft lip and the full palate. Of course, if you're not sure, you can always draw it. When you refer the case to your oral surgeons or the orthodontist, you can always draw these pictures. Draw the lips, then draw the palate, then you just draw it according to your finding. That will be easier. So, of course, we can diagnose the case even before the patient is born. We can do some ultrasound. So, cleft lip is easily detected using the ultrasound. But cleft palate is difficult. Why? Because you cannot see through. You cannot see through the lips ultrasound can see the external of the baby, but I cannot see the internal. So you see all the baby, mostly they are closing the lips when taking the ultrasound. Hardly you see the baby open the mouth. So this one is difficult to see whether it have a cleft palate or not. But you can see there's a cleft lip. Okay. But sometimes if the hand cover the head or the lips, then maybe you cannot see. That's why sometimes you cannot see baby is female or male, because they are covering the important part with the hands or with the limbs. So you can detection of the other abnormality. Sometimes you can have the ears, the nose abnormality. Then you can prepare the patient's parents psychologically, and then all the complications, possible complications. So ultrasound sometimes is good to determine or to detect the cleft, so you can prepare the patients, prepare the parents early. Their baby is going to have a hard life. So that's why some of the country, some of the other countries, not in Malaysia, they allow abortions if they detect the cleft, but not in Malaysia. Not in Malaysia. So the problem with the cleft lip and palate, it can cause an aesthetic, obviously. If you have a cleft on the lips, then this one will cause aesthetic problem. Then feeding is the most important thing. So when the baby born, you don't concern about aesthetic, but you worry the baby cannot take enough food or the milk from the mother, then they will die. Hearing can be problem because sometimes the cleft affect the ears also. They cannot hear very well. Sometimes you can have ear infections. Speech can be problem. We all know the speech, it depends on the tongue position and the seal between the tongue and the oral cavity. So if they have clefts, and sometimes you cannot seal it very well, then they say cannot pronounce certain words. So that's why you need the speech therapist to come in for the team also. Facial growth disturbance, this one we know. Sometimes they have maxilla, mandible is not developed normally. Then dental abnormality, this one is very common. Then sometimes they have less teeth, more teeth, or a lot of time their teeth is not well aligned or impacted. Infection can be if the food can go into oral cavity, cannot maintain a very good oral hygiene or nasal hygiene, then can cause an infection. Psychosocial, this one is the most important. Like I say, when the baby is born, the parents is traumatized. And after that, with so many treatment going in and out hospital, the kids are traumatized also. So at the end, the whole family is traumatized. So that's why you need a very strong support from the hospital, be it dental or medical, even the social worker also sometimes will come in. So there's a website called Cleft Palm, I think, Malaysia, Cleft and Palate Malaysia Associations. You can go to their website. They have so many activities to connect all the patients and the parents with the cleft. So this one I think is very important. When you have this cleft, you don't want to be alone. You need the support from the group. So if you listen those experience from the previous parents, how they deal with the cleft, then it's more encouraging. So I think that website is doing a good job because sometimes the patients are in the low economic group, they cannot afford the surgery or braces, then that society will fund their treatment, which is quite good, quite good. So some parents that are quite rich, then they can put our fund, then support the poorer patients. So this aesthetic problem can be the nasal shape. You see the nasal, then usually collapse. You see this corner of the mouth is collapsed. So sometimes you have a flat nose, and even they repair the cleft lip palate, then sometimes you leave a scar. Then this scar can be quite obvious. And the lip functions is compromised. Then patient cannot smile because the muscle sometimes after the surgery can be linked or there are scarring tissue, which make the smile not as natural. So same thing. So you see the early repair for this lip, then the patient gonna have a good wound healing, and in long term they have a better aesthetic. So you leave this cleft and palate for too long without repair, and the scarring tissue will be more obvious. So usually cleft and palate, we try to repair it at the right age, the right time, and just to make the result better. So, like I say, the first thing the baby born, the most important problem is, are they going to survive? That's the most important. So if they are not going to have a lip seal, they cannot suck or cannot create the seal to the nipple of the mother, then it's have difficulty for this feeding problem. So it's difficult to suck, and milk may go into the nasal cavity, cause a infection to the nasal cavity. Then even though the milk can go into the cavity, then sometimes without proper seal, then it causes frequent regurgitations. It means the milk can go into the stomach and then they come out again to the oral cavity. So this one is very dangerous because it can burn the throat or it create ulcer or so many problems. So upper respiratory tract infections, if they cannot swallow very well, sometimes this food or whatever the dirt can go into the respiratory tract. Again, it cause infection, sometimes cause pneumonia. So that's why when the baby born, then we sometimes offer the patients or the parents, they use a special feeding bottle. So you see this is not a normal feeding bottle. They usually, this one is a very soft, very soft. So you can pump the milk a little bit. Then you see the head or the bottle is modified. It's just not like the normal feeding bottle. Sometimes they are modified the head to a little bit bigger, so the patient can have a seal to the palate. So this one is so many design, so you can Google it. Okay, it's like this one is bigger, different design. The hearing and speech problem. Some cleft patient can have hearing loss. Then sometimes they have infection or pus to the ears, otitis. Then getting hearing loss, then harmful the speech development. Cannot hear, then you cannot speak. So that's why the patient sometimes they have a problem communicate with the patient's parents. So we have to be very patient, when patient have this problem. Then there are poor pronunciations, hypernasal sound. Hypernasal sound is very common because when they start developing the speech ability, if they always pronounce or they make the sound through the nose, then they will have this tendency to have a nasal sound whenever they pronounce certain words. So even after they repair, the cleft, and if they repair it too late, then everything is already set in, then patient tend to have this hypernasal sound. So what's the dental abnormality? It can have a abnormal size and abnormal shape, and have a peg-shaped lateral is very common, and sometimes conical lateral incisors very common. Small lateral incisor very common. Sometimes not only small lateral incisor, can be small central incisor, other premolars, can be rhombus shaped. So many problems. So enamel defect, some patient get hypoplastic, which is a weakened enamel, pitting, or the hypoplasia. It's very important, very common. Very similar to your fluorosis. Then delayed eruptions, direct sedulations. So impacted fused teeth is very common also. Impacted canine is very common because doesn't have the full alveolus. They have a cleft, then that's why cause the impaction, because the teeth cannot erupt without the bone. Hypodontia, it can be less teeth, natal, neonatal teeth, or postnatal, after the birth or before the birth. So supernumerary supplemental extra teeth, common. Displaced, even though they erupted, it can be displaced due to the cleft. Rotations, crowding, displacement, very common. So occlusal abnormality, then when they're back together, you can see the anterior or posterior having crossbite. So sometimes we can do one side unilateral, can be bilateral, can be just anterior, or can be posterior anterior together. So posterior open bite, this one also very common. And for occlusion, because due to the failure development of the alveolar process. So like I say, no bone, no teeth. So if there are less development for the bone, then the teeth might tend to stuck or infraoccluded. Crowding, very common, not enough space, then not enough bone, then the teeth will be crowded. Spacing, due to sometimes missing teeth, can be spacing. Malalignment, crowding, very common. Midline shifted. If the left side is having cleft, then most likely the midline is going to shift to the left. So let's look at these pictures. You see there's a cleft, then it causes a lot of crowding. And then even though the teeth erupted, it might be rotated. Like this one, central incisor rotated. And even though they erupted, it might cause a crossbite. Okay, narrow arch is very common. Narrow arch is very common. So when you have a repair on the palate, then it causes scar tissue. Then this scar tissue will hold everything together. That's why the arch is constricted a lot of time after repair. So this repair maxilla or mandible, maxilla, maxilla, then it causes a restriction of the development of the maxilla. A lot of time it causes a narrow arch of the upper and the tendency of castry after the repair due to the scarring tissue. So this one is castry. You see the right side, the picture is castry. So what is skeletal? They have tendency to castry due to the maxillary retrusions after the repair of the palate or the lip sometimes. Then maxillary growth is restrained due to the palatal scarring tissue following the closure of the palatal clefts. So we are in the dilemma, you want to repair it, but you don't want to cause scarring tissue. So that's why the best time to repair is when the patient is still young. So when you're young, it causes less scar tissue. When you're old, you repair it, it causes more scar tissue. Because the ability to regenerate, then it's better for the young patient compared to the old patient. So, okay, scar tissue that contract the place that a constricting force to the maxilla. Yeah, scarring tissue will hold everything. Constricting is more severely anterior due to the collapse of the alveolar. So a lot of time the cleft is here, then repair here. That's why constriction is more in the anterior. If you repair the posterior, then the posterior will constrict. Depends how bad is the cleft. Okay, you see the tendency of castry. The patient, when they grow up, then because the upper maxilla restrains or restrict, then patient the lower mandible growing forward normally, abnormal, normal directions, then normal growth on the mandible, then the maxilla restrained or restricted. That's why patients have tendency of castry. Castry. So if the castry is too severe, then we have to deal with orthodontic surgery later. So imagine you repair the lips, then after that repair the palate, then after that you have to repair the jaw. So there's no stop, no ending for these cleft patients. They have to go in hospital so many years, so many times. So, but if you according to research, there are features for the unoperated cleft. Let's say if you do nothing, and at first we say the scarring tissue will cause restrictions of the maxilla. But what happens if you didn't repair the cleft? So there are some researcher or the doctor, they did some study. If you didn't repair the cleft, then you should have a normal maxillary development. I mean the maxilla develop as normal. They don't have the castry features. Maxilla was more anteriorly positioned than the non-cleft patients. Okay, some report of the increased FMPA is slightly smaller than mandible. These are not significant. So I'm trying to say if you didn't repair the cleft, then the patient should develop normally. So it should have a normal maxilla mandible. But if you repair it, then high chance the patient is going to have a castry skeletal features. So minimum effect on the facial growth after the surgery. So the lips surgery is not too bad. If you repair early, then there's normal, the maxilla still can grow. But if you repair the palate, then a lot of time they cause a lot of scarring tissue. The more traumatic the surgery is going to be, they cause more scar tissue, and they cause more restriction to the upper maxilla development. So minimum effect on the facial growth after soft palate. Soft tissue is not too bad. Usually hard palate, it causes a lot of scarring tissue. So other problem can be nasal fistula, but if you didn't repair, you have a nasal fistula and have a nasopharyngeal incompetence. So you have to repair it to get the function, right? But you get a side effect, which is scarring tissue, will restrict the maxilla growth. By leave it without repair, it causes other problem, fistula, nasopharyngeal incompetence, cannot swallow, cannot speak very well, aesthetic also compromised. So what's the management of this cleft and palate? So the aim of treatment, the first thing, function. Function is more important than aesthetic. Like I say, if you cannot survive, then no point we're talking about aesthetic. So function always come before aesthetic. So a lot of time when patients have a consultations for braces. Then if they're poor oral hygiene, then we always don't start the treatment. The reason why? Because the aesthetic is not that important when it comes to function or basic. So always settle the basic problem first, then only will talk about aesthetic. Same with the functions. If you cannot have a healthy gum or periodontal support, then why we have to talk about aesthetic? It's no point. So first improve the function, then second improve the aesthetic. And treatment of the cleft and palate patient require a team approach, not only the orthodontist, but involves so many specialists, medical and dental, and sometimes the social worker or the psychologist. So you see the team can be a plastic surgeon from the medical side, ENT surgeon, deal with the ear, nose, and throat, then pediatricians, then speech therapists, audiologists, they deal with the speech and the hearing problem. Then oral maxillofacial surgeon, a lot of time we do this cleft repair, then there's argument, which surgeon is doing better. If you ever work in hospital, there's always an argument. Plastic surgeon and oral max-fac surgeon, they always fight the case. Some say they are doing better than the others, so never ending. So I personally think the lips repair, then maybe the plastic surgeon is doing better. But when it comes to the alveolar bone graft, ABG, I think our team is doing better because the plastic surgeon not much. They know not much about the dentitions. A lot of time they don't know what we want compared to the max-fac surgeon. So you have a different team, then sometimes they are overlapping between two teams. They're doing the same job, then defend the personal preference. You send to a different team. So in the hospital, sometimes don't have plastic surgeon, you got no choice but to send it to the max-fac surgeon to do the lip repair. Then where you have the orthodontist to align the teeth, sometimes a lot of time you need to align the teeth before the ABG. We'll come to that later. We have the pedodontist, and then this one will deal with the caries and extractions. Because a lot of time, these patients, they are traumatized, then they have a lower social income group. They don't take care of the oral hygiene that well compared to the other normal kids. There are a lot of times the oral hygiene compromised, then they have mouth caries, then they need a lot of treatment from the pedodontist. Psychologists, same thing. Like I say, the kids are traumatized, the parents are traumatized. Sometimes you need the psychologist to come in, social worker also to support them mentally, or sometimes financially also. So what's the treatment schedule? When to treat the lips, when to treat the palate, when to treat the teeth, or when to treat the jaw. It's very critical. So if we do the right thing, right time. So when above, then we have an initial and pre-surgical assessment. Then the counseling, counseling the parents, then support them. Then give them some feeding advice, give them special device how to feed the kids to make sure they survive. Because in order to do a surgery, the cleft lip and palate repair, the patient must be grow big enough. If there's a tiny little baby, maybe cannot survive from the surgery. So first thing, must be able to feed them well, let them grow well before the surgery. So we have to do the record also. Then after 3 months, then we do the primary lip repair. Repair the lips first. The lip seal is very important so the patient can suck and they can feed better. Then after that, 9 to 18 months, then we repair the palate. Then after 2 years, then we have the speech assessment. During 3 to 5 years, we have the lip revision surgery. Second surgery if necessary. Sometimes the first surgery cannot repair the lips perfectly, then we need the second surgery to do that. So some patients might go for 2 or 3 times just for the lip repair because the lip is aesthetic concern. So a lot of times they try to make it as normal as possible. So then one surgery cannot be done, then we have to do second surgery, third surgery, just to improve the aesthetic outcome. So 8 to 9 years, then we have intercepted orthodontic because we have to prepare for the canine to come down. So if the cleft alveolar, then without the bone, the canine cannot come down. So they prepare the alveolar bone to receive the bone graft. Then usually we have to open the space, align the teeth, make everything nice and straight. So the surgeon will come in and pack the bone in the middle. Then the canine can come out after about 11 to 12 years old. So usually we do it. The ABG is about 10 years old. So development of the canine is about 10 years old. So you should be able to see the eruption of the canine, if everything go well, about 11 to 12 years old. So after the canine erupt and or the permanent dentition established, then it go for definitive orthodontic treatment, provided the jaw is not too bad. Let's say they are too severe class 3, then we tend to wait until they are 17 to 20 years old. Then we do another orthodontic surgery. So this one very subjective. Huh? So we have to assess the patients carefully. So let's say they are not too bad, then we start ortho. If they are very severe class 3, we tend to wait until they stop growing. Then we do orthodontic surgery plus the braces together. Then about 16 years old, they have a nasal revision surgery again. The first time they didn't repair the nose very well. Then they do the second surgery later. So you see, from the birth until the patient is 20 years old, so many surgery line up waiting for them. So I have a patient, I remember, a patient, I treated the patient for 10 years. I didn't treat the patient for 10 years. The initial first few years by the other orthodontist, but I finished up the case. When I debond the braces, the patient crying, cannot control herself. So after 20 years going in and out the hospital, then finally she has a nice outcome. Of course, not perfect, but much better than before. So I will advise all of you have a bit sympathy for cleft patients. Be a bit patient, to them, because whatever they've gone through, you cannot imagine the kind of stress and amount of hard work. Not only the patient, the parents also. I remember these patients, the father used to fetch her with a motorbike from a small city to the clinic, which take about 1 hour. Imagine for 10 years, how much of hard work and mentally exhausted for the parents. Okay, so what's a pre-surgical orthodontic? So to reduce the cleft size, then after that it can help the surgery. Then we have a partial obturator, then the aid feeding to help them to feed better. Then we have the parental assurance, reassurance, just try to comfort the patient parents. Then we have this maxillary strapping. So you can see this is a maxillary strapping. So you can try to bring the premaxilla backward, closer to the lips, closer to the cleft. So it makes the cleft a bit smaller, so easier for the surgeon to come in to repair it. So we have this nasal alveolar molding appliance, NMA. So this is an example for this NMA, nasal alveolar molding appliance. So you see, have this palate, cover the palate, seal the palate. Then we have this component like a spring. So this one attached to the premaxilla. So by activating this spring, then this premaxilla can come back, which is closer to the cleft side, then easier for the repair. So this NNA is to move the nasal cartilage or the premaxilla, and it will reach to reduce the severity of the defect before surgery. So imagine if this premaxilla is so far sticking out, or so far from the other part. So this cleft is difficult to repair. Such a big defect is very difficult. So you try to use this appliance to bring the premaxilla backward, then closer to the cleft side, then easier for the surgeon to repair. So there are so many designs. So different surgeons have different preference, but the purpose is similar. They modify the premaxilla or bring back then closer to each other, then easier for the surgeon to repair it. So sometimes because the patient doesn't have any teeth, then you cannot have a proper palatal seal. So sometimes you have to put some denture adhesive just to create a better seal. Then we have this elastic strap. So you see beside this palatal seal or palatal cover, we also have two components stick out a little bit. So you can attach the plaster or some elastic band so you can push the premaxilla back. So we have this elastic strap. So attached to this appliance. So same thing, we have the plaster, or just to bring this back a little bit so the surgeon can repair the lips better, easier. Same thing, different design, but similar component. You have the strap, left and right side. Then after that, surgeon can repair it. So lip repair is about 3 months. So the complications, even though you can repair the lips, sometimes because they're too far, or the design of the flap is not that well, then sometimes even you bring it together, it doesn't join. So it causes a decision, then excess tension might tear off the wound, then sometimes cause an infection also, if you didn't keep it clean. So this, you need a very good surgeon. That's why I say sometimes the plastic surgeon might be a better person to do the lip repair. Because the suture they use is very fine. They use maybe 6O sutures. It's like your hair, very fine suture, and the aesthetic result outcome is very good. See this one? If you repair it early, then it can look normal, almost normal. Of course, you can see some scarring tissue, but not very obvious. Same with this one. Repair it early. Patient have a good development of the soft tissue, and this one become less obvious. So a lot of cleft patients, if for the female, the man, they tend to grow repair palatal lip, cleft lip, then can repair it early. So palatal repair you tend to wait about 9 to 18 months. Then you repair before 18 months, then patients can have a better pronunciation or speech or articulation error less likely. Well, okay, if you repair it too late, then maybe patient you tend to have a hypernasal speech because when they learn how to speak, it's very critical at that moment. Once they get used to using the nose to pronounce certain words, then maybe they'll continue to that, become a habit. So you have 10% articulation error if you're done before 1 year old, but you raise up to 86% error after 1 year. So if you do it before 1 year, then maybe patient have a better speech. If you do it after 1 year, then most likely patient going to compromise that speech. So there's so many techniques or so many design for the cleft palate repair. So you see the basic concept is the same. They relieve the tension from the left and right, then they cut the soft tissue, then they join it together. Same with this one, even though a VY, same thing. They just relieve the tension from the adjacent tissue, and they put it in the middle, then they join it together. Same thing, relieve the tension, then join the middle. So same, this is just a picture. They repair the lips and repair the palate. Same thing. So just now the lip repair and the palate repair, a lot of time, sometimes it's not by you, but you have to know when is the best time to refer the patient for the APG. Sometimes the cleft patients, after a while, they disappear from the hospital and they didn't come for follow-up. And suddenly they turn up in the clinic. Then you have to refer them back to the hospital at the right time. Because some patients, they prefer not to do it in the hospital, the review or the follow-up, because they are traumatized. They don't want to go to hospital anymore. They prefer to do it in the clinic. Absolutely fine. As long as you can do a good job, fluoride therapy, then restore the cavity, then arrest the caries, then you have to refer the patient back when the times come. So when's the time to do the APGs? Very critical. So what is the functions or the purpose for APG? Is to provide the bone for eruption or reposition of the teeth. Without the bone, the teeth cannot erupt. Imagine the canine cannot go into the empty space or erupt into the air. Must have the bone, and only the teeth can erupt. So the bone graft also, the purpose is to close of the oral nasal fistula. So if they have a fistula between the nasal and the oral cavity, you have to seal it or you have to close it to divide the oral cavity and the nasal cavity back. Suppose have two separate cavity. And they also, if you put a bone, then they support the elevation of alar base. Alar base is side of the nose. Side of the nose. Sometimes, like I say, if the cleft they collapse, flat nose, you put a bone graft, you can elevate the nose a little bit, so they get a better aesthetic outcome. Stabilization of the premaxilla for the bilateral cleft. Again, if you put the bone back, then they join together in one piece. It's better than a few pieces walking around. Provide continuity of the alveolar region. Again, then join everything together back. So the maxilla should be one piece. The final outcome should be one piece. Maxilla is one piece. And so that's the reason why we do the APG at the right age. Very important. Okay, so primary bone grafts done during the first 2 years of life, then done prior to the eruption of primary canine. So this one in Malaysia is not very common. Maybe in US they're more common. They do the surgery quite early, so they call it primary bone graft. In Malaysia, they are more prone to secondary bone graft. So secondary bone graft is done before the eruption of the permanent canine. Both also canine. One is primary, one secondary. So Malaysia, we're more focused on the permanent canine. Then usually the root of the canine is 1/3 to 2/3 form, about 8 to 10 years old. So when they start forming the root, that's the time they should be erupting. So that's the time we do the APG. Okay, so we prepare the arch for secondary bone graft, take about 6 to 12 months. So when the teeth is not straight or the gap is not there, then the surgeon cannot pack the bone into the cleft. So that's the reason why you need a pre-surgery orthodontic to align the teeth, sometimes open up the gap a little bit, so the surgeon can come in and operate nicely and pack the bone at the correct place. So you prepare for the secondary bone graft, take about 6 to 9 months. Just simple alignment, open the space, take about 6 months to a year, then patient ready for the surgery. So the arch has to be expanded to expose the actual size of the defect. So sometimes if you see, because they repair the lips or repair the palate too early, everything will string or the constrict narrow arch. So you need to use an expander to expand the arch again back to the normal size before the surgeon can come in to pack the bone. So dentition next to the cleft may need the orthodontically reposition to prepare for a orbital bone graft. Again, like I say, they are not straight, they're crooked, and not enough space, difficult for the surgeon to operate. But this usually have to do with the fixed appliance. So a lot of time, I told you, the fixed braces should be only put on if the patient have the permanent adult teeth or extra bridge. So in this situation, because the patient have a mixed dentition, we only put the partial braces, which means sometimes 2x4 or sometimes 2x6, only on certain teeth, just to align the teeth, then open up the space. So this is a typical example for the expansion device. This one I call it quad helix. So you got four loops. You call it quad helix, 4 loops. Quad helix expander, then the expand the constrict upper arch after the palate repair. So we expand it, then the surgeon can come in into the APG on the canine area. So you see the main idea for the APG to create the continuity of all the maxilla. The maxilla should be in one piece. So now we have 2 or maybe 3 pieces. You see the premaxilla and the primary palate and the secondary palate are not joined together. So we have to make this in one piece. That's why I have to stuck the bone on the cleft regions, just to make it in one piece again. So same thing, position the teeth away from the cleft. So you see on the left side, there's not enough space for the surgeon to pack the bone. Then after that, we use a coil spring to open up the space. So the surgeon can see the cleft bevel. At the same time, he can pack the bone. No space, sometimes difficult to operate and difficult to pack the bone. So bone graft. So, yep.
Just now got a few slides. It's a delay in changing. So I think,
Oh, okay. Thanks for telling me. So you see the site to get the bone graft is so many resources you can take from. But the most common one is from the iliac crest, which is from the left or the right side of the iliac crest. Then if you are right-handed, then sometimes you tend to take the left side, or left-handed take the right side. But they pick one side. They pick one side first, then which is not going to affect your walk or the walking or the moving ability later. Let's say the cleft is too big, huge, or bilateral cleft. A lot of time they involve both iliac crests. I mean, they take the right side, not enough. They're not going to stop there. They have to harvest from the other side. So this patient end up both leg cannot walk after the surgery. If the cleft is too big, then he might operate both sides. So sometimes they will take the bone from the mandible, especially the angle of the mandible or the symphysis area. So you can take some bone, and you can take some allogenic bone. It means from the cadaver or from the same species, like human and human. Of course, not from the live human, from someone who's already died, then they donate, and the bone can be used after the process. So if you die, then maybe it's a good idea to donate the organ, to let it go into waste. Someone should burn it, then why not you donate to someone who needs it? So alloplasty, same thing, synthetic bone. So sometimes you can do some other than human graft also. Sometimes you can use the bovine graft or the cow, or sometimes you can use artificial graft or xenograft. So this one you can go for the implant courses. They'll tell you all type of graft. But most commonly used in Malaysia is the Iraq crest. They take from their own, left or right, or sometimes both. But it might ask, in long term, are they going to affect the leg or the mobility of the patients? Young patient, no. They will recover very fast. And of course, they will leave a scar tissue on the right hips or the iliac crest area. But usually that area is covered, so it's not causing too much aesthetic concern. So typical example, you use the quad helix again. This one to expand the upper jaw. So the surgeon come in and pack the bone. So you see when they cut the cleft site, then they usually draw it with the surgical marker and where they want to cut and how they design the flap. You see, before they start this alveolar bone graft repair, you see the scar tissue on top. That's by the previous repair for the lips. So if you do the APG again, it cause more scarring tissue. So that's why when they design the flap, they have to be very careful. So same thing, after they raise the flap, they see the defect, then they will decide how much of bone they're going to harvest. The bigger defect, then the more bone you need to. So after that, they pack this bone in, pack it nicely, and cover the flap back. Then hopefully the patient bone will stay. Whatever you do the graft, we want it to stay. So sometimes the bone graft will resolve or they disappear. Then unfortunately, you have to go for second bone graft again. So again, second bone graft, maybe this time we take from the left, and the next time we take from the right. Or if your both side also is already done, then we take on other side like mandible or use some artificial bone graft. So sometimes these kids are not only surgery, not only one surgery, multiple surgery. Poor kid. So you see they pack the bone, they pack it nicely, and after that they close the flap. Okay, same thing. You see the expander. After they expand, open up the space with the braces. Then they come in and repair. Then after the repair, you see the canine can erupt. You see this X-ray, it shows that the empty space or the air or the discontinuity between the premaxilla and the postmaxilla. So this one, if they didn't put the bone graft, no bone, then the canine cannot erupt. After they pack with the bone, then the canine can erupt nicely into the place. So you see after the bone graft, see the side of the nose or the ala base, this one can raise up a little bit. So the nose from the flat to come a better form. So the bone graft can raise up or turn up the nose a little bit or the premaxilla area. So after that, then you wait. After the APG, they consider, okay, settle the canine eruption. Then you wait until the patient have a permanent dentition established, which is after 12 years old. After 12 years old, then they have a full permanent dentition. Then that time you decide whether you want to go for full braces to correct everything. That time, I think you have to assess the growth and the skeletal pattern. So this time, usually we have to look at the correction of the anterior crossbite, and sometimes the arch will collapse again. Then you need some arch expansion using a quad helix or the RME or expansion screw, or sometimes you put the face mask also, just try to reverse the castry if they're still growing. So if the skeletal pattern is not too bad, then you go for the full braces, comprehensive treatment, then just align the teeth to the nice position, then consider done. Then you monitor the growth of the maxilla and mandible. But let's say there are too severe class 3, then maybe you can wait. You see this patient from young, 4 months old, until 20 years old. 20 years of treatment, how many surgery have done? How many braces have done? So not easy, not easy for the cleft patient to get this final result. So same thing. Oh, I see this one for 4 months old to 21 years old. Okay, only the surgery is done. Everything's done, nice and straight. After 20 years old. 2 severe class 3. You see this one restricted too badly. The upper jaw is too small compared to the lower jaw. This one is beyond the scope of orthodontic surgery. Sometimes the maxilla can advance about 10 millimeters, which is 1 cm, or maximum maybe 1.5. That's the maximum for the orthodontic surgery. So this patient sometimes can consider distraction surgery, which is putting a distractor in the maxilla or mandible. So in this case, the maxilla, we put a distractor and fracture the upper jaw, distractor, then keep turning this screw, then the distractor will push the maxilla forward. By putting a distractor, they say it can advance the jaw more than the orthodontic surgery. So again, the distractor, the expert is Professor Firdaus Hariri. I think he can visit the UM website. You can see more of his work on internet. So see this one, class 3, after orthodontic surgery, becomes straight profile. So what's the conclusions? So managing this cleft and palate is a lifelong process, not easy, take a long time, 20 years of treatment. Even sometime after 20 years, they still follow up the patient. It's a lifelong process. So you need a team approach, not only yourself, you need so many specialists, then involve a plastic surgeon, MaxFac, and orthodontist, social worker, speech therapist, so many people, ENT. So must come to work as a team. That's why in the government, we have this joint clinic which involve dental and medical. Depends on what the patient needs. Then all the specialists come to discuss about the case. Then they come up with a final plan. Then only we execute the plan accordingly. So one time joint clinic sometimes not enough. Then they bring the patient back from time to time, discuss again what is the current situation, what's the development. Then we replan the case again. So the plan is not final. They keep changing. That's why it's so difficult to treat these kind of patients. Orthodontic treatments aims is to produce functional, aesthetic, and stable occlusion. So not only aesthetic, we are talking about functional. So functional, I personally think is more important than aesthetic. So if without the function, don't talk about aesthetic. So there are some people who may disagree with me. So when I see people cut away the teeth, then do multiple crown, or they take away the incisor, then do a long bridge just to settle the overjet aesthetic fast, I just feel so painful when I see that. So don't do that. Don't do that. Functional first, aesthetic later. So if you do the opposite, I don't say you're from Masa. I didn't teach you that. So stable occlusion again, hopefully. That's why sometimes you need the orthodontic surgery to come in. You get a better occlusion. So with that, I thank you. Do you have any question to ask me?
Doctor, you said the cleft and palate got supernumerary, right? I mean, is it because of the cleft and palate, or because you also got some development?
Yeah, some other problem. When you have a craniofacial problem or craniofacial sign and symptom, then you notice they can have a supernumerary, can have a hypodontia. So sometimes one side can have less teeth, then the other side have more teeth, even in the same mouth. So I would say it's genetic, mostly genetic. It's not due to the cleft, mostly genetic.
Okay, thank you.
So if you look at the research, there are certain genes will cause the supernumerary or cause a hypodontia. You can look for it. I think it's I don't know what's it called, hexox or something. Yeah, the gene. If you're interested with genetic, I can go ahead. Just Google it. Any more questions? So this one, I don't expect you'll know everything about the cleft patients and the treatment, but I just have to know the basic, when to repair the lip and when to do the APG. That's it. Yeah, and the most important, you know what's the purpose of the treatment, is to restore the functions, then make your patient survive, then later, if possible, aesthetic. Yeah. Any more questions? No, no questions. If no questions, I think we end here. I think I will see you on the next lecture. Yeah. Good day.
Thank you, Doctor.
Yeah, welcome.
Thank you, Doctor.
Thank you.